Hello, everyone. Welcome to another edition of What's Up, Doc, where we provide an opportunity for people with poor circulation in their legs, known as peripheral artery disease, to ask a doctor questions live. I know that it's so tough to get in to see a doctor these days, and there's a lot of time between appointments. Sometimes you don't even see the doctor. Sometimes you see a PA. Sometimes you see a nurse practitioner, and you have all these questions, and maybe you get 5 minutes, maybe you get 10 minutes most with your healthcare team, and you walk away with more questions than you had while you were in there, because doesn't that always happen? When you're in there, you can't think of everything. So we don't give any sort of medical advice. Everything we tell you here, you need to go back to your own healthcare team for explicit consent to follow any advice or information followed here. Your healthcare team knows your situation best. We do always suggest before any procedure to get a second, even third opinion to make sure you do understand all options, but this does not count. Watching a video does not count as a second or third opinion. It's only to provide you with a little bit of guidance to be able to help you make a more informed decision on the questions that you're going to be able to ask your doctor. So start to take notes, but that's the limit, okay? Just got to have that disclaimer out there. Without further ado, I'd like to introduce our doctor of the day. It is Dr. Nikhil Patel with AVA Vascular in Murrieta, California. That's in Southern California, a little bit between San Diego and Los Angeles area, Dr.
Correct.
Patel?
Correct.
Okay.
Orange County and San Diego area. Yeah.
And he has had a couple really miraculous saves with our patients. And he also performs, so you not only can ask about peripheral artery disease, but you can also ask about osteoarthritis in your knees, because he performs an additional procedure known as genicular arterial embolization, where they can go in and with a minimally invasive approach to try and get rid of some of that inflammation in there to hopefully relieve the pain in your knee if you're not a surgical candidate for knee replacement. So get your questions ready. Dr. Nick Patel is here to answer a lot, but the reason that we had Dr. Patel on today is because he and I had a very important discussion about peripheral artery disease recently, because in our network of 12,000 patients with the Global PAD Association, we have seen a lot more cases where a patient is asymptomatic for poor circulation, known as PAD, in their legs, all the way up until they end up with a wound on their foot that won't heal, and they're an advanced stage PAD before they're even diagnosed. And in the textbooks, they say don't do anything with a PAD patient if they're asymptomatic or if they have what's called intermittent claudication, meaning they walk, they get a leg cramp, when they stop, it's relieved. And I'm thinking, Dr. Patel, the disease state has changed in the past few years with the increase in diabetes, the increase in chronic kidney disease. Can you just walk us through this whole scenario of the disease progression and what you've seen in presentation, and how maybe the symptoms are presenting differently than maybe before?
Absolutely. First of all, thank you for having me today, Kim, and the team. It's a great pleasure to be here and discussing this very important topic, which is PAD and critical limb ischemia, which is prevalent all over the world. I think we have to distinguish between claudication and rest pain, because these are under the same umbrella as PAD, but they present totally differently, and to the extent almost opposite. If you think about claudication, people get leg cramps when they walk, but rest pain or critical limb ischemia is pain at rest. So that's, opposite of what claudication is and rest pain to start with. Now, a lot of us have been trained in diagnosing PAD as a presentation as claudication, which was very true in the 80s when smoking was very prevalent. Diabetes wasn't so prevalent at the time. And that time, smoking affected the bigger blood vessels in your body, like the aorta, the iliacs, the femoral arteries. So when these big blood vessels get blocked, when you walk, you have a lot of big muscles in your legs, so they need the blood flow to keep you going. And when they're blocked, you present with a cramp. And when you rest, it gives allow the blood to, reach to your muscles in your legs, and then you feel relief after 5 to 10 minutes, and you walk again, you get the same claudication again. So that is very true for, when you have claudications from smoking related or high blood pressure, high cholesterol, because it affects the bigger blood vessels. Now it's totally different. I like to see it as smoking, affects the blood vessels from the top down, and diabetes, end-stage renal disease. And the third category of patient we see nowadays is people are living longer. So older patients, their disease is more critical limb ischemia. They don't get the claudication. And that usually starts from the toes and comes up, just to help you differentiate why this disease are, totally in the opposite spectrum. Now, if you have disease that blocks your toes and comes up, if you look for claudications, you're not going to see claudications in those patients, because claudication is a symptom of blockage of the blood flow to the large muscles in your calf and your thigh. So if you think about today, diabetes is way more prevalent than smoking. Because of diabetes, people also get end-stage renal disease. So end-stage renal disease is another disease that affects the smaller blood vessels. Then you see people living longer these days. So even though they don't have diabetes, but they can have critical limb ischemia. That's a misunderstanding that you got to have diabetes to have ischemia, which is not true. You can just be 70, 75-year-old and have small vessel disease in your feet presenting with, critical limb ischemia. So in our training, we always thought about claudication as PAD. So we always been trained to check patients' ABI and check pedal pulses. If they're normal, then you kind of sort of rule out your PAD secondary to claudication cause. So a lot of people are still doing that these days. They check an ABI, it's normal, but the patient's got a wound on their foot. That's because ABI is only checking the perfusion up to your ankle, because that's where you put the blood pressure cuff. But the disease is beyond the blood pressure cuff into your foot. So you're missing all that disease if you're going to rely on ABI, And some of these patients will have a palpable DP and PT pulses, pedal pulses, and they have a wound because their disease is beyond that ankle where you feel the pulses. So that's one distinguish that you got to make between claudication and rest pain, presentation-wise. So because the disease presents differently, the symptoms are also presented differently. So if you look for claudication in a patient with diabetes or a patient with end-stage renal disease or an older age person, looking for claudications or ABI, they're not going to have claudication. If you tell them, hey, they can walk from the parking lot to your office without any problems, is when they sleep at night, that's when they get the cramps in their toes and the forefoot. And the reason being is if you think about the physiology of it, when you're sitting and standing, the gravity helps bring the blood down to your feet and toes. So when you're sitting, standing, your body's, accommodating by, with the gravity's help to bring the blood down to your feet and toes. But when you're sleeping at night, your heart is at the same level as your legs, you're horizontal. So your heart is pumping the blood, but it's not getting to your toes. So initially what happens is your toes get cold and numb, then they get stiffened up, then they get you get cramps. And subconsciously, you automatically sit and put your feet on the side of your bed, and now the gravity helps bring blood down, you feel better. Or you get up and walk around, you feel better. Then you go back to this sleep again, and then it starts again. So that is classic for, rest pain due to small vessel disease in a diabetic patient or patient with end-stage renal disease or older age group patients. So if you look for claudication, intermittent claudication in these patients, you may not find it, So.
And so with these patients, how do you determine when to treat? What if they don't have a wound? Are these patients that obviously their lifestyle is not being hindered by this. So that is one of the qualifications for having a procedure. If they're having these leg cramps, we just had a patient that was reporting that they were having foot cramps at night, and they ended up having some lower velocities down below the knee. They went and had a CT angiogram. The CT angiogram was unremarkable, supposedly, but it was also a doctor that doesn't tend to treat below the knee. So we've never seen this CT angiogram. We don't know. Another vascular surgeon came in and said, well, since you don't have traditional risk factors of diabetes, it was a very young patient. And I've seen this a lot in a young patient with some hypercoagulability. This person had a clotting instance following a back surgery, DVT, Eliquis took care of it. But is it possible that there was some, BTK disease or in the foot disease, maybe some clots that got down there, or possible, I mean, it could be what? Um, Vessel congestion induced by edema, you don't know, but does a CTA tell you these things?
Yeah, so the clotting is a little different than PAD or critical limb ischemia, because clotting is an acute event. It happens suddenly. Critical limb ischemia, claudication, they happen over many, many years. And CTA is good to look at the blood flow up to the knee, but beyond the knee, the blood vessels get small. Then you have calcification on top of the blood vessels. So it's really hard to detect. The timing of the contrast has to be right when we do the CT scan. So all those, a lot of variables in making a decision. So therefore, tibial and pedal disease is very difficult to diagnose with CT angiogram. Aortoiliac SFA pop, I think, is great. CTA is great for that, or even MRI. But when it comes to tibials and pedal disease, I think your physical exam, how the patient is presenting to you, their symptoms, are going to be your major decision-making tools, and even the Doppler exam, that you can do.
So when a person presents with no other symptom, no other risk factor except foot cramps at night that are waking them up, what would be the gold standard for you? Would it be going in and doing an actual diagnostic angiogram and sending an IVUS and maybe going pedal, going through the foot to come up and just check it out? Or what would you do?
Yeah, so I don't think I would jump straight to angiogram. I think your clinical evaluation and symptomology will be very important. For example, we have to distinguish the cramps at nighttime between cramps in the toes and the forefoot, because that's where critical ischemia is. It basically involves the toes and the forefoot. Now, patients will have cramps in their calf muscle at nighttime when they sleep. That's not from, usually that's from simple dehydration. They haven't drank enough water, or they walked a lot that day and they didn't drink enough water, so they get cramp. So that is a big distinction between cramps at night. We have to go to the next question and ask, where exactly is your cramps? And it has to be in the toes and the forefoot to be in the category of critical limb ischemia. So let's say they do have, cramps in their toes and feet, and they're diabetic.
With lower and with lower velocities.
Yes.
In an ultrasound.
Exactly. So you can do, there's another tool that you can use with ultrasound called pedal acceleration time, PAT. That's a great tool, but a lot of it requires a different skill set for the technologists to do that. And most labs will probably don't have that. If they have it, that's an additional tool you can use. Instead of an ABI, you can use like TBI, toe brachial index. So we have a little blood pressure cup that fits on the toe, and you measure the toe pressure and the brachial pressure, and you compare the difference. So because toe pressure is more distal, so you can pick up all the disease, up to the toe, which is where the disease is in these patients with diabetes and end-stage renal disease and older age group. So these are other tools that are available, and obviously your physical exam is going to be the key. Normally, if you feel the temperature of the leg, in these patients, if they have small vessel disease, you just put the back of your hand from the leg and come down to their feet and toes, and you can see the temperature difference as you come down. The toes are colder compared to the feet and the legs. They have absence of hair, because hair needs blood flow to grow new hair, so they want to have hair. The skin will be dry and scaly because the skin needs nutrition, perfusion, and if it's not getting it, it gets dry and scaly and flaky. Then you also get the nail beds, which are brittle, or they get constant fungal infection in their nails. which doesn't clear because you don't have the blood flow to grow new nails. So these are all the different things that we can look for in a physical exam, in these patients. A lot of these patients will also have neuropathy in their feet. The thing about neuropathy is not directly damage to the nerves from diabetes, but it plays a role through the arterial circulation. Is when you have small blood disease in the foot, which are blocked, that leads to neuropathy. So nerves are not getting the nutrition and the oxygen that leads to neuropathy. And we've seen patients where we open up their pedal loop or, pedal vessels, the neuropathy improves, because now the nerves are getting the, oxygen and so forth. So, and the double-edged sword of neuropathy is that when they have neuropathy, they don't feel anything. So they may not feel the cramps, they may not feel the pain, or they step on something sharp, they don't feel it, and that's what leads to the wound. Or they're wearing their shoes that are tight and they don't feel it because of neuropathy, and the tight shoes leads to a blister, which leads to an open wound. So it's a very, you have to understand the pathophysiology to know what questions to ask. One of the questions I ask my patients is, first thing they come with critical ischemia is, do you sleep okay at night? All of them who have critical ischemia, they said, no, I can't sleep at night. I'm like, okay, why? Well, my feet get cold. I have to wear, socks or a blanket, and sometimes they cramp up. So this is how we dig out the information from the patient. Because you have to remember, this is a chronic disease, and it happens over many years, 5, 10 years. So some of these patients think, they've gone older during this time. So they just feel, I'm supposed to feel this way because I'm getting old. I'm not supposed to walk, or I'm not able to, I'm supposed to have cramps in my feet, because I'm old now. Or they have problems with their balance because of the neuropathy. They have frequent falls because they don't know where their foot is going, where they're stepping. So they have balance issues, and they've been worked up for balance issues with MRIs of their brains and everything, and everything's normal. But the problem is the circulation in their feet.
Mm-hmm. Mike seems to have a question right now. Mike, do you want to unmute and ask your question?
Where are you? There you are. No, I was just listening to what you were saying there, and I don't think that I've got limb ischemia, but I do have toenail fungus infection, and my feet at night. I mean, I don't get rest pain at night. I can sleep the whole night through. But occasionally, my feet feel as if they're cold to touch on the outside, and it comes up to my knee. Is that a cause for concern at the moment? I do a lot of walking every day. I'm quite healthy. I quit smoking in February. So I'm doing everything that I've been told. I'm just wondering, with what you've just been saying, that it could be ischemia, that I've just started kind of worrying a little bit that even though I'm doing everything right, it's what you're saying just seems to be different to what I've heard before.
Right. I mean, you have other medical conditions like diabetes and, kidney issues,
No.
anything like that. Nothing, just smoking was your main. So you probably had more claudication symptoms and rest pain.
Yes, yeah. I was getting claudication pain after 5 minutes of walking, but ever since doing the treadmill and doing the exercises that my doctor told me to do, I don't actually get any claudication now unless I go on a high incline.
Right. So most of your diseases major in the bigger blood vessels, the SFAs, the popliteals, and the iliac. Your tibial vessels, pedal vessels are probably okay. But you do. I mean, I'm not saying rest pain. These symptoms are only related to critical ischemia. There can be other causes, that can cause. Vasculitis is a thing. People who smoke, they get a lot of spasm in their blood vessels. So it could be these things. So once you change your lifestyle, change your, nutritional status, sometimes it could be just malnutrition, low magnesium or things like that. So these are the other things. But my point was that when you have small vessel disease, they present this way. These are the things you look for. The absence of cold feet, fungal infection in the nail, so forth. So these are all some of the signs and symptoms you look for. It doesn't mean that if you have that, you have CLI.
Right. Okay.
Yeah.
Okay. Thank you.
Yeah.
How about Douglas? Douglas, go ahead and unmute and ask Dr. Patel your question.
Yes, sir. great to have you with us. Awesome. And two quick things. Number one, I think you kind of explained why we get this question a lot, cold feet.
Mhm.
Why do I have cold feet at night or during the day? And then the
Yeah.
second one is kind of from the very beginning. I belong to a healthcare unit here. We have a van that goes out to 6 different counties. I've been pressing upon them a lot about talking about PAD, and this question came up in a staff meeting yesterday. How would you, in the very beginning, somebody comes in and says, I'm having trouble, and are there some, the question would be, how do you distinguish between it might be PAD or the back issues? Because in the beginning, we get all these different answers. You know what I mean? Well, I pulled a muscle. I did this. I did this. And we understand that if you push a shopping cart leaning over, it can help you distinguish. And I was wondering if there was something that I could say to that nurse practitioner that might help her understand that a little better. I hope
Yeah.
that makes sense.
No, absolutely. I mean, so there is a lot of symptom correlation between back pain and claudication. So claudication, for example, using the steps in staircase in your house, if you're going upstairs, into your second floor of your house, most of the time you're leaning forward. And, if you have pain during that time, it's usually claudication, your legs, you have circulation issue because you're leaning forward. So that takes away the pressure from your disc, if you had back problems. But when you're coming down the steps, you're always sort of leaning backwards and coming down. So that exaggerates your back pain. So one example would be, do you have pain when you walk up the steps or when you come down the steps? This is some of the questions. I mean, it's not a 100%, screening tool, but it tells me what's going on. If they say I have pain when I come down, it's most likely it's a back issue problem. But if they have pain when they're going up the steps, it could be their, circulation issue. So it's all how you question, because everybody's symptoms are different to their own body. So you have to connect with the patient first. That's what I have to do first, learn their lifestyle. What are they doing? And then ask them the questions that are relatable to them for them to answer your questions correctly. You can't just go through a checklist and say, you have this, you have this, you have this, you have this. You'll miss a lot of diagnoses that way. I think first and foremost, you have to connect with the patient. You have to understand what their lifestyle is, and then ask them relatable questions, that they're able to comprehend and understand and explain. That's my way of doing my consultation. Because if I just go through a checklist, you'll just mark a lot of things. Do you have leg pain? Well, I do have leg pain, but that's shooting and sharp pain. That's not vascular. Is it cramps when you walk? And how far can you walk before you get those cramps? So it's how you ask questions and how you receive information, and then ask a secondary question to the patient that they can relate to. So you can diagnose a lot of stuff just by your physical exam and asking the right questions with the patients.
And we have a question that is coming in from Renee. She wants to know about whether you can have PAD and varicose veins too, and what's the difference between those two situations. Of course, you have veins versus arteries, but I'll let you take it from there and provide the proper explanation.
Sure. So that's a very good question, because a lot of people get confused between arteries and veins. So arteries, the heart pumps out the blood to all parts of your body, and the blood is carried. That's the oxygenated blood. That's nutrition blood that comes out from the heart that goes to all parts of your body, and those channels that carry that blood is called the arteries. So they're going into your feet, and then the blood has to return back to your heart, and it returns to what we call veins. So these are different channels. Arteries carry the blood to their feet, and the veins carry the blood back to the heart. So when you have arterial problems, you have symptoms, what we've been talking about for the last few minutes, the claudications and rest pain and all that. When you have varicose veins, the blood was supposed to go up, but it's not going up, it's returning back to your legs. And it gets worse as you stand and sit for a long time. because these veins, these channels, they have a valve that opens up one way, so allows the blood to go up, and then the valve closes, so the blood doesn't return back. And when these valves don't close all the way, there's always some leakage of blood that keeps accumulating, and it goes to the most dependent portion of your leg, which is around your ankle. So as you sit for a long time and stand for a long time, all that blood is accumulating down your ankle. So if you notice, when you get up in the morning, if you have varicose vein, when you get up in the morning, your legs feel the best because you've been lying flat, your legs been draining, and as you start your day, the gravity's, pulling more blood down. So as the day goes by, your legs get heavier. And when the legs get heavier, they get tired also, So, and there's, simple tests we can do, like an ultrasound test to determine whether you have varicose veins or arterial disease, is easy way to differentiate this, between varicose veins and arterial disease. I hope that explained that a little bit.
It did. No, that was great. And Douglas and I were having a conversation the other day about the impact of smoking on the arteries, and he had a great question on trying to understand the actual mechanism of action by which the particles, right? Everything that's burned, it's whether it's a regular smoke from a fire, whether it's something nicotine with chemicals you're smoking, or whether it's even marijuana, it's the particles, right, that travel into the lungs, ultimately into the bloodstream and throughout your body. Can you talk about this entire process and walk us through from the moment you puff the cigarette and how it ends up in your bloodstream and throughout the body, clear to your toes?
Yes. So I think patients who've had PAD and patients who have not had PAD and who are smoking, right? Their symptoms going to be presented a little differently. So if you, I guess in a simple term, if you smoke, it causes damage to your inner linings of your blood vessels, and it makes them unstable. The plaque becomes very soft, and it can break very easily. Even when we do intervention in patients who are active smokers, we tend to get more dissections, more embolies, because they make the vessel plaque very unstable. And that is all. It's hard to explain in a simple term what the pathophysiology it is, but in layman's term, it just basically, as you smoke, the byproduct of smoking causes damage to your endothelium of the blood vessels, which leads to plaque buildup over time. And when the plaque builds up, your vessels are getting smaller and smaller. And that's how you get claudication symptoms in a smoker. And in addition to that, sometimes when you're smoking, you also get spasm in your smaller blood vessels. So if you notice people who are smoking and they stop smoking for 4 to 6 weeks, overall, they feel better in their circulation because they have not done anything to the plaque, but they've relieved that spasm from the smoking inhalation. So even, I have patients who tell me, I just smoke 1 cigarette. I said, I tell them, it's not even 1 cigarette, even 1 puff of cigarette, if you smoke, that's going to your body, that's causing that spasm and giving you the symptoms. So you really totally got to stop smoking altogether if you want your symptoms to improve, I don't know.
And we have some patients that say, well, the smoking, I need to smoke because I have pain. It relieves the pain in the few moments, but then the pain comes back and then I have to have another cigarette. And it becomes this vicious cycle. How do you talk to patients about breaking that cycle?
Yeah, that's very tough, breaking that cycle. I think that's what we feel the most difficult part of our practice is how do we convince these patients to stop smoking, and how do we convince this patient to control their A1C? If you can do those two, I think we will have a big impact on PAD. And one of the ways, I think that's where you have to, there's no one, way to have patients stop smoking. I think you really have to engage with the patient and figuring out what they're going through in life. A lot of these patients have their life stresses, their parents are not well, they're taking care of them, or they have problems with their children, and it's stress, or their housing issues, or there's a lot of stresses in their life, and they've been smoking cigarettes because of the stress all their life, and suddenly you tell them to stop. It's very hard. So I think to some extent you really have to give them the reality check. Say if you keep smoking, you're going to lose your leg. Simple as that. And a lot of them don't want to lose their leg. And I go to the extent saying, even if you do, forget smoking one cigarette, just one puff, if you do, that could be your last puff to leading to an amputation. So I think you just have to connect with the patient, with their lifestyle, with their environment, and then figure out a way to how to enter their mind to tell them, hey, this is how you can stop this. Maybe create, instead of smoking, chew a gum, or find other ways that can distract them. I had a patient about a month ago. He had an angiogram done, intervention done, and it re-occluded again because he kept smoking, and he had a wound this time. So I explained to him that this wound is not going to heal until you stop smoking. And I explained to him that, see, you've been smoking all this while, even after the intervention, and your wound hasn't healed, because you not only the smoking causes the plaque to be unstable, but you're causing spasm every time in your blood vessels when you smoke, and that's not allowing the wound to heal. And I said, you're one step away from losing your leg. So either you keep smoking and lose your leg, or you stop smoking and save your leg. And I think that really clicked to him. And then he completely stopped smoking, just cold turkey the next day. So you just have to connect with the patient. There's really, there's a lot of programs out there registering these patients for, this cessation of smoking programs is a good thing. But I think until they connect to what's relevant to them, they're not going to stop smoking. And only way to do it is a physician talking to them one-on-one.
And Douglas is a retired addiction counselor in the state of Texas, and he provides peer support every Monday night for patients with PAD. And we're working on launching a quit smoking program for patients specifically designed for PAD. Douglas, did you have a question for Dr. Patel based on your experience?
Yeah. So the question is, as a counselor, we kind of drinking, we know, like the liver. As long as you don't have cirrhosis, the liver will technically grow back to kind of where it was in the beginning once you quit drinking. Can we explain that somewhat to our smokers, that will our arteries and our veins go back to a condition that is healthy once we stop smoking? And is there like a time frame for that? Because we hear all the stories. You quit, and a day later, most of this stuff is gone. 3 days later, this stuff is gone. Is there as long as we're walking, we're building collaterals, will our veins or our arteries kind of do what the liver kind of does, go back to original status or whatever?
No, I don't think there's any data on that. I think once a plaque is there, it's there. Just because you stop smoking, the plaque doesn't start dissolving in your body. But it helps with the spasm part, and I know as far as the lungs go, your breathing improves after you stop smoking, and it almost takes 20 years to reverse that smoking effect when it comes to your breathing. When it comes to peripheral artery disease, the plaque is there, but a lot of the improvement they get I believe, is from the spasm that's no longer there when you stop smoking, but the plaque buildup is still in your arteries.
So it's still there, but once we quit smoking, then we're not piling on to it.
Right. If the smoking is your only cause, I mean, some people have smoke, they have diabetes, they have high cholesterol. So you have these other factors that are still playing the role of progressing your disease. Smoking is one thing only. So.
And what about when it
marijuana in that category? What about those self-inhalers that aren't cigarettes? Are those, because we get that question a lot.
That's a great question. I don't know if you have enough published data to say it's good or bad, or most people think is bad at this point. But I mean, I think anything you take in your body, you have to take it in a mindset that this is going to affect your body in some way or other, right? If you take good things in your body, you're going to have good things. If you take bad things in your body, it doesn't mean you counteract with good things is going to off balance the effect. A lot of people will say, okay, I'm going to eat this, turkey, which is, high oiled and cholesterol, but long as I drink like or eat like blueberries and raspberries, I'm healthy. But no, that's not true. You try to counteract the effect of the others, but you have to stop eating that and then eat this. So I think people have if I stop smoking, but if I start marijuana, is it better? It's really not, because you're really putting something in your body that we have no data yet to say what's good or bad, right? So I think if you eat healthy, live healthy lifestyle, then you're going to have a healthier body. But if you take into your body things that are damaging, which you already know they are, or you don't know, obviously they're going to cause damage one way or the other. You may not see it now, but you may see it 10 years from now.
I have a question that is coming in from a patient out of the UK. And it's a little disconcerting. She shares that, she has some sort of iliac blockage and she has rest pain that wakes her up at night. She's been in a wheelchair with so much pain and she tries to use her treadmill. She's stopped smoking. The doctor in the letter to her says, well, she's now managed to be able to get a wheelchair and has been able to leave the house a lot more. Although she's hampered a little bit, she still gets around. So I think that it's best if we continue to pursue a conservative course, although it would be nice to take away her sleep disturbance. And so she prescribed oxy and is it amitriptyline? Amitriptyline.
Yeah.
And what is that?
So I think, for her, she has iliac occlusion. I'm sure she has other vessel disease too, for her to have rest pain. And the fact that she's wheelchair bound, she's not able to walk, so she's not able to build those collaterals, So for her, intervention of the iliac arteries would be very important, because she's taking all these medications just for the rest pain. And if you can improve the blood flow, why not do that? I mean, if she was ambulating, and she stopped smoking, which she already has, but if she's able to ambulate, she's going to build those collaterals slowly over time. But if she's already wheelchair bound, then you have to intervene. You can't just wait and watch these patients when they have occlusive disease and they're bed bound or wheelchair bound. You can put them on all these medications, but again, you're just making them dependent on medication because of their symptoms.
Yeah, it's just interesting. We find this a lot in the UK and a lot of the smaller communities, not in places like Manchester or London or just some of the larger hospital systems, and especially the university hospital systems there. We do see doctors, especially if there is that sort of rest pain. The patient's only 38 years old, which is sad. She does have severe COPD, but we were told that when it comes to iliac occlusions, that it's a lot tougher with those really large arteries to grow those collateral vessels, enough collateral vessels through walking to be able to really, especially at age 38, to be able to satisfy what the legs need for an active lifestyle. And, just going in there, I guess the first course they were looking at was to do a full bypass as frontline treatment, which does seem, I mean, for 38 years old, it does last like 30 years, but probably extreme for someone like this. Going in, wouldn't you say, with just the kiss of a balloon? I mean, those iliac endovascular procedures are usually fairly durable if a patient has quit smoking, is on the right medications, and they walk afterwards.
Absolutely. That's first line treatment is the endovascular treatment for these, iliac vessels. First line would be the medical management or non-invasive management, which is walking, exercise, and all this stuff. But if they're not able to do that, then you can't just leave the patient alone and say, keep trying. I think you need to intervene at that time, to improve her lifestyle.
Yeah, I always tell people, I mean, at the very least, try for 3 months, walk, 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 do as much as you can, because no matter what, the collateral vessel growth is going to benefit you. Even if you do need a procedure after 3 months, those collateral vessels are really, really important to have, because it's not a matter of if procedure is going to fail at some point, it's a matter of when. And the whole guide is that it's only to give you enough flow to build those collateral vessels so that when they do go down, you have enough collateral vessels at that point to be able to maintain you. But
That's
the
exactly
rest
right. So
pain is what,
I'm sorry, go ahead.
no, the rest pain is what concerns me. And just giving people, just masking the symptoms is really concerning in this case.
I totally agree. So there's probably more to than just the iliac occlusion in her, I feel.
There is a question coming in about whether PAD can affect the genitalia area. A little cold to the touch around the area on some days, but mostly after being on the treadmill.
So a PAD can affect if you have vessels that are in your pelvic area, like the iliacs, the internal iliac arteries, which supply the genital organs. That can cause, with male, you can erectile dysfunction and things like that. So it does affect your pelvic circulation with the genital organs, but they present differently in male and female. We know that in males it affects their erectile functions.
Wow, we have a patient that just posted, why are we seeing so many 30-somethings here, coming up in the past couple of years, so many 30-somethings. This one actually, the patient had COVID, ended up with a blood clot, also osteomyelitis 2 times in the feet, 6 weeks on IV antibiotics, caused the left toe to be amputated partially. Also has polyneuropathy, had an ABI, TBI done not too long ago. Blood flow is good until it gets to the ankles. I have severe lack of blood flow in both feet. Left side is worse. This is exactly what you were talking about in the beginning. Right foot is about a 0.4. Left foot is 0. Has anyone had this happen, and what's possible to treat in this particular case? What should she do? How should she talk to her doctor? What questions should she ask?
Yeah, so COVID, unfortunately, we know that COVID causes hypercoagulability and thrombosis. It affects smaller blood vessels. I had a patient during COVID time with gangrenous, fingers, both hands after having COVID. So unfortunately, there's no endovascular intervention we can do, to open up the blood flow to, especially those small blood vessels in the feet and toes, unless she has additional disease in the tibials or the iliacs, which we can treat to improve the blood flow. But really, I think if it's to the point where it's gangrene, then you have to amputate. Unfortunately, we don't have good options when you have a lot of distal disease, especially from thrombosis, occlusion from not plaque buildup, but acute blood clot and chronic blood clot on top of that. So.
Yeah, it doesn't sound like she's had anything done. She doesn't have anyone trying to improve the blood flow. It just looks like they're trying to treat, the symptoms, just trying to, treat the foot. But if you don't have enough blood flow to the foot, the IV antibiotics can't get to the toe where the infection is.
That's right. That's what we were talking about initially when we started this conversation, is that in a patient with a wound, especially who's a diabetic, who's a critical limb ischemia patient, they get an infection, and the infection can travel to the bone, and now they have osteomyelitis, and now they need IV antibiotics for 6 weeks or 8 weeks. And what happens is that during the IV antibiotics, their infection is improving, and then you finish the course of the IV antibiotics, but the infection has not cleared all the way through, then it reoccurs again, and they start another course of IV antibiotics. And one of my thoughts is that, why are these patients are taking, repeat cycles of IV antibiotics without improving their circulation? Because until you open up that blood flow to that wound, the antibiotics has to travel through the bloodstream to get to the wound. And if you don't have blood flow to the wound, then it's kind of going everywhere else but the wound. So you really need to, get the blood flow open, start the IV antibiotics, and now you'll see it working, the wound healing, the infection clearing. So it's very important to work hand in hand when it comes to critical ischemia, to work with the other physician groups like the infectious disease, the wound care, the podiatrist. It should be a team approach in managing these patients.
And Douglas has another question. Go ahead, Douglas.
Yes, sir. So we're in our 60s. We build collaterals. We got good collaterals. We get in our 70s, in our 80s, we get this question. We tend to slow down a little bit. Do we maintain those collaterals only by walking, or do they digress as we get older and we slow down?
I think the answer is in your question, because as you slow down, then your need for the blood flow is also less, to your muscles. But you have already built those collaterals over time when you're active. So you have your natural bypass, So your natural bypass is adequate to provide enough perfusion or blood flow to your skin, to your nails, and, so forth when you're not walking as much, So it's like somebody who gets a heart attack and who's an avid runner, he works out in the gym, he does a treadmill, 3 times a week, but he still gets a heart attack, but he survives a heart attack compared to somebody who does not do any exercise and gets a heart attack, because he has higher chance of dying, because the person who is exercising, he's already built those collaterals over time, so he has a better chance of living even though he gets a heart attack, compared to somebody who does not have collaterals. He gets a heart attack and he's dead, so exercise not only helps you, it doesn't basically stop the disease process, but it helps you to survive it, these collaterals.
That answer your question, Douglas?
Yes, ma'am.
We have Sherry, who is online, and she said she was in bed for about 7 years with pain so bad, and all they would diagnose her with at the time was neuropathy. 7 years, and she became bedridden, and they still had not checked her circulation. Is this something that you have seen in terms of patients that have come your way for a second opinion, that you shake your head and you say, how in the world was this person not diagnosed with PAD sooner? And why is this still happening in 2025?
Absolutely, Kim. I had a patient who was referred to me for knee pain for arthritis. And then on evaluation, I found peripheral artery disease, So she kept saying, I have pain in my knee that shoots down to my legs. And then it just, it wasn't a point tenderness, which we look for when we do knee exam. It just didn't meet the picture of an arthritis at the knee. It was more like rest pain. And he worked them up and, she had peripheral artery disease. So these patients, can present in different way, and they've been worked up, in different ways. But a lot of people don't think about vascular disease as a cause of simple thing as, patients having balance issues or having frequent falls. They think of neurological first. So they get worked up with MRI as the brain, they get the carotid ultrasound done, but nobody looks at their circulation in their leg. And that's where the problem is. So yes, medicine, it's not simple, it's not straightforward, it's a puzzle that you got to put it together, and every patient is a new puzzle,
Okay, patient Karen with dark purple, her foot turns dark purple, that's the left foot more than the right. Numbness, tightness, heavy weight, dead weight in the left lower leg, swelling in both legs, but more in the left versus the right. ABI results show a blockage in the left leg below the knee. The first doctor has not shown any concern, said it's fine, doesn't matter if you have those symptoms, but she does have a family history of strokes and heart attacks. Was a former smoker 23 years ago, 1 to 3 cigarettes per day on average. she is getting ready to go for a second and even third opinion. What should she be asking for, and how does she know if she needs some sort of procedure at this point?
Right. So she's probably a patient who has both arterial and venous disease. So she probably, I think she's already been worked up and known that she has PAD with the blockage below the knee. I think the edema, the left leg swelling, more compared to the right. It could be like May-Turner syndrome that we know that affects the left side more, which is a venous outflow obstruction. So she may have a component of both arterial and venous disease. So she would be, need to have worked up for both. Look at the arteries, look at the veins as well.
Fantastic. And for either one, I mean, it's always a tough decision, tough call. I mean, but frontline PAD guidelines say unless you're being woken up at night with leg cramps and you can't get back to sleep, you have to dangle your legs over the side, and or you have a wound that won't heal. That's really your best bet is still medication therapy, and walking as medicine as frontline.
Well, that's true for claudication, not true for rest pain. I think critical
Right.
ischemia, yeah. Rest pain, I think you have to intervene. There is really, walking will help you, but it's really not going to get rid of your rest pain because it's all small vessel disease. It's hard to build collaterals in the foot compared to your thighs and your legs, So I think it has to be evaluated, determine how bad is their rest pain? Is it really affecting their lifestyle? If it is, then you have to intervene. The medications and walking was not going to help those patients when they present with critical ischemia. On the other hand, when patients have wounds, we tell them to walk, but they've been told by their podiatrists, you can't walk until the wound heals. So this is like a difficult situation for patients, or even I've had patients who had PAD, but they have mild swelling in their legs from their PAD, and they've been told to elevate the legs, which is making their critical ischemia worse because now you're making makes the challenge for the blood to go up to your toes. So there's a lot of misconceptions. You have to figure out what the disease is and then advise these patients correctly. So you can't apply walking in a patient who has a wound because now they can't walk. So you have to come up with different options. I tell my patients to do ankle exercises, like you're pressing on a gas pedal and relieving it, do that 30 times every hour, because they can do that anywhere at any time. My patients come up to me and say, I have this stationary bike pedal, can I do that? I said, of course you can do that, but you're only going to do that when you have that with you. Otherwise, the rest of the time, you're not using it. So best thing to do is do these exercises. You can do it while you're sitting in the car, going to your doctor's appointment. You can do it while you're waiting in the doctor's waiting room or while watching TV. And that really has made a difference in these patients, because they're not able to get up and walk. But at least they can do these flexion and extension exercises to improve their circulation in their feet.
And finishing again where we really started, just to drive home the point that there is a new presentation of PAD, and that is in late stage PAD known as critical limb ischemia. And whereas before it was a disease of someone who, smoked, and was a disease of old age, but a lot of those people that ended up getting it as they were older had a history of smoking, was my understanding. And so they would have larger vessel disease and they would end up with claudication pain, cramping in their butt, their hips, in their calves as well. But what you're seeing more, my understanding, is people who end up with a bottoms up approach, right? With the diabetics, people with also hypercoagulability, also even older age people without the history of smoking, probably likely either pre-diabetic, diabetic, issues with their kidneys, especially end stage renal disease. But also we see it with chronic kidney disease patients as well. With these patients that are asymptomatic when it comes to the traditional indications for PAD, right? The claudication when you're walking that relieved at rest, which it'll progress if not treated to the rest pain and that wakes you up at night, and potentially wounds that won't heal, right? But it's these patients that are getting the bottoms up approach that are not going to present in that series. They will be likely asymptomatic until suddenly they end up with rest pain that wakes
Yes.
them up at night.
Yes. So it's important thing that you mentioned that rest pain is a late presentation of PAD. I think they're two separate entity under the spectrum of PAD, because you don't necessarily have claudication beforehand to have rest pain. You can start with rest pain. So I think a lot of people think, okay, you present with claudication. These claudicants can also progress to rest pain. But patients with diabetes, end-stage renal disease, older age group, they can present with rest pain without the symptom of claudication.
Right.
So I know we think of critical ischemia as a late stage of PAD, but I think it's just a separate stage of PAD, because I feel they're two separate entities, claudication and rest pain. Although they're under PAD, you don't have to have claudication before you have rest pain. You can have,
right.
So a lot of us are trained to look for claudication, which we won't find in these patients with rest pain.
And so with these patients, it's just they've got to intervene. You said that they're less likely to be able to build collateral vessels in these smaller vessels to relieve the symptoms.
Yeah, unless they have claudication that has led to rest pain, then you can improve the big blood vessel blood flows and then treat them and improve their symptoms. But if they had diabetes, end-stage renal disease, and their older population, then they usually have just small vessel disease if they're not a smoker. So
fantastic. You cleared up a lot for us. Thank you so much. I think that was such an important discussion to have, because we're getting people are like, I don't understand where this came from. I don't have normal symptoms. My doctor won't touch me, and I can't sleep at night. And I'm starting to get something forming on my toe. And what are we waiting for? We do have patients in the UK that have told us that my doctor literally, and we see it over and over again. We just had it posted the other day by two patients separately, that my doctor told me literally to come back when my toe is black. Then they'll treat them.
yeah.
That's really disconcerting. I think it's an old way of thinking. Now, granted, we do have people that are treating too soon. It's a handful of people. I know the media is making it seem as though it's a grander number, but in our experience, it's a smaller number of people. We have more doctors that will amputate without any sort of vascular assessment at all prior to. We have doctors that will provide an amputation without any attempt to open up the arteries. They say you have small vessel disease. There's nothing we can do. You can walk. When you can't walk anymore, we'll just cut it off. And those are the majority of people we see when it comes to amputation. We still do see some doctors, and we know there's a handful of them that are treating in the very, very early stages of, claudication, or even lifestyle limiting claudication, to where it's not really affecting their job. They really aren't taking the time to walk. They won't stop smoking. And yes, come on, at that point, the patient needs to take responsibility. They need to take their life into their own hands. They need to change their diet. They need to lower their A1C. They need to quit smoking, and they need to start moving. I mean, they got to do something for themselves, right?
Absolutely. It has to be work as a team, physician and a patient being a team. I tell my patients, I'll do my part, but you got to do your part of not smoking, for example, or controlling your sugar. There's really, it's like patients, they come with severe claudication and they have, FEMPOP disease. We treat them, but they continue to smoke, and I tell them, you continue to smoke, you're going to shut down whatever the work I did within 3 months. And then we got to go back and do it again. So, but a lot of them are not given that message, so you need to really engage with the patient and communicate with them to let them know how severe this disease is. If they don't improve their smoking or improve their A1C and things like that. So,
yeah, I've had patients come to me and say, my doctor won't treat me. And I said, well, if you have the rest pain that's waking you up at night, if you have, wounds that won't heal, but if your A1C is still high, if you're still smoking, it's only going to close up again. It's going to be a revolving door of treatment. And so you got to take your health into your own hands and do something about it. That's why we offer every Monday a 30-minute diabetes reversal meeting with our world-renowned diabetes reversal expert, Dr. Michael Danzinger. It's every Monday. Patients can come. It's almost like having your own personal dietitian or a food doctor every single week, 30 minutes with a doctor every week to answer your questions. And then we have Douglas and with his teammate Becca, every Monday, peer support group for smoking cessation, every single Monday. And both of them have gone through addictions themselves. They both have training in counseling for addiction. And it's a really great support group every single Monday. And then we talk about walking. We have our walking support group. We have our walking program that people can sign up for. It's an app, they can download it and track their progress, measure that claudication time. And there's so much that the patients can do on their own, especially in the early stages. So it's really important to do so. Thank you so much, Dr. Nick Patel. Any final thoughts before we head off into this 4th of July holiday weekend?
No, thank you for having me for this great discussion. I hope I answered everyone's question. I think PAD, or the spectrum of critical limb ischemia, or limb-threatening ischemia, as is also known as, it's very prevalent, more than we think of. I think a lot of patients have been delayed in their diagnosis or misdiagnosed. So as a CLI fighter, I think we have to do our best to find these patients and treat them appropriately at an appropriate time. And someone like you being a front runner as a patient advocate is so great to know that patients have so much resource these days available that they can access and get the right care and the right physician that they need to treat the disease. So thank you for what you're doing for the community.
Thank you, Dr. Nick Patel with AVA Vascular in Murrieta, California, between San Diego and Orange County, California, Southern California. If you have questions about PAD, you just want to talk to a PAD navigator, you need help finding a doctor, you want to talk about some of the lifestyle modification programs that we have that may help you improve your prognosis, you can call our Leg Saver hotline that's right up here in the corner. That's 1-833-PAD-LEGS, 1-833-PAD-LEGS. Don't forget to like this video if you like everything that the doctor is saying here and you've learned so much. Subscribe to our channel. We have doctors and clinicians on every single week to answer your questions live. So don't miss a thing. Get notified. Hit that subscribe button. But thanks so much. Hopefully everyone will have a wonderful 4th of July holiday.